So the next talk will be by Dr. Chandrasekhara. He's going to tell us on managing patients on DMARDs with different common illnesses and surgery in periphery. Dr. Chandrasekhar needs no introduction. He has already spoken to you before. Thank you.
Good afternoon. I think in next 20 minutes, I'll just quickly make you to go through. Having started disease modifying anti-rheumatic drugs, quite often it's called immunosuppressive drugs, we need to handle these group of patients. See, if you look into the possibilities, even if you think of only rheumatoid arthritis, it accounts for 0.6 to 1% of the patients. If you add other connective tissue disease, other autoimmune disease like multiple sclerosis, etc., where we are going to use few of these disease modifying anti-rheumatic drug and immunosuppressives, you have up to 3 to 4% of the population who are on one of these disease modifying anti-rheumatic drug or immunosuppressives. Whether you are a surgeon, orthopedic or general, or whether you are a physician, or any other specialty for that matter, you may or you are going to face one of these patients with one of these drugs along with 3% of the population being used with one of these drugs. We are bound to face, and we need to know to some extent how to manage and handle them, because each time it is not right on any one of us to say that, oh, you are on this drug, you go to the respective consultant or the specialist, because each problems could be unique and separate. So the attention, why we should specifically care about these patients, we have a little difference when a patient with diabetes comes. We have not much of things to worry with when a patient with hypertension and antihypertensive comes, because there are, in a diabetic, we know he is partially immunocompromised if he is not managed properly, but when it comes to immunosuppressives, we are clear that he is to some extent immune suppressed, because we have what I otherwise called as an extended interference of these DMARDs as well as immunosuppressive therapies, some amount of immune system interference, which otherwise is responsible for maintenance, management of the entire ecosystem. And we need to know about the toxicity profile, because as you are going through with the previous lectures, no DMARD is an ideal drug. We don't have a DMARD which has less toxicity. Exceptions were hydroxychloroquine and sulfasalazine to some extent, but even they do have some amount of interference. So we do not have a typical ideal drug where we can say it has least interference in other activity of immune system and it only handles the autoimmunity of rheumatoid arthritis. It doesn't happen like that. It has an extended interference in immune system, and we all know once we start these DMARDs, patient need to be on this for a long term. So it is inevitable that the patient needs an attention when he is on DMRD, and he need to be attended with as a special case with some additional issues or problems to be ascertained. So the major issues or dilemma we face when we need to manage the patients with disease modifying anti-rheumatic drug is, should I pass the DMARD or not? Should I stop this DMARD? Patient comes with a fever, he is on methotrexate or leflunomide, has joint pain still on. Can I stop his methotrexate or leflunomide for a short while, a week or 2 weeks? The first question that we face is, should I give a pass or should I not? And if the patient is on steroids already, shall I stop it because he has an infection? Because we all know by reflex, steroid is an immunosuppressive and it interferes in fighting. Actually speaking, if the patient is on a steroid for a longer time of more than a year or year plus, it is absolutely wrong to stop the steroid immediately, for a simple reason. Most of the patients on steroids, if it is beyond 6 months or 1 year, his adrenal axis, hypophysis adrenal axis would have been interfered. Normally when a person gets infected or goes into stress, the steroid output increases. If you suddenly freeze or cease the steroids in these patients, you may rather put the patient in a hypotension and other crises rather than helping him way out. So you need to take a call, can I stop the steroids or should I not stop the steroids? Preferably it is best not to stop the steroids. You can reduce if you think, but it should never be reduced beyond 7.5 or 10. The reason is, patient when he has an infection has a stress which requires an increased outpouring of steroids. especially when the patient is on a long-term steroids, it best never to stop the steroids or more to fiddle with the steroid dose. Then comes, is this drug safe with the drugs which I am going to use in emergency? If I use an antibiotic, does it interfere with leflunomide? Does it interfere with the drug which the patient is already on? Can I use a combination of two drugs at this point of time? So the next question comes is the safety and drug interaction, what we are going to use with these disease modifying anti-rheumatic drugs. And the fourth dilemma we will face with this, patient has a fever, patient have a change in some functions, is it because of the disease and disease modifying anti-rheumatic drug itself? You might have heard previous speakers saying leflunomide can cause a drug induced fever. Sulfasalazine is notorious to cause a drug induced fever. The patient walks in with a fever after 3 months or 4 months of introduction of DMARDs. You find every investigation is negative. Is it just because of the DMARDs? So, or the next worst scenario to happen is it because of the worsening of the existing disease? I think you will see few of the cases being discussed in the afternoon sessions in the workshop, how these dilemmas or confusions can prevail and how to negate these kind of circumstances. We need, when we are managing, these are the 5 major dilemmas which we are going to face when the patient is on DMARD and steroids, walks in with some other problem. So patient walks in with a problem, say a rheumatoid, walks in with a fever. Now we have various questions which we have to address ourselves. So that's how the patients on DMARDs need little special attention. So, thus, see, it is the necessity of the family physicians and everyone who is taking care of these patients, because patient may have small flare of the disease. For example, in SLE, small increase in rash, a rheumatoid, small increase in pain, and any other systems. Each time and every time, one, he cannot afford to see a rheumatologist. Number 2, he cannot get an appointment with a rheumatologist. So it becomes a responsibility of a family care physicians or any other primary care physicians to handle these small flares. Minor adverse reactions like gastric irritation, dyspepsia need more consoling and adding some more to that. And association of comorbid status like diabetes, hypertension, which needs. And our recent study, which we did a cohort study, a group study over various rheumatologists, we could see that 20% of the patient has one or other comorbid conditions which needs to be managed, and rheumatologists cannot handle these comorbidities alone. It needs a family physician or someone to take care of these associated comorbidities. So thus, a care of these patients on a DMARD is a coordinated effort between the primary care physicians as well as rheumatologists on various aspects of management of these particular patients. How do we handle minor flares? If there is joints, pain, swelling and other manifestations, we need to make ourselves clear whether it is a true flare or it is a flare or worsening of the pain because of any other exertions. Because if the patient exerts too much, walks around or discontinue NSAIDs or alter the drugs, there could be a minor flares. It could be single joint or multiple joints. These can be handled at periphery by increasing NSAIDs or giving one shot of depomedrol or handling or altering his exercises and other patterns. So that's how one can handle the minor flares when the patient's on disease modifying anti-rheumatic drugs. So the major concern when it comes is if it is a non-increase in the immune disease, you need to just counsel them, increase them NSAIDs. If it is too serious a flare, one need to refer or take adequate help from whoever the rheumatologist or the specialist who is handling these patients. It's not just the disease which flares when you are on DMARDs. It could be a infection or patients coming with the fever. The problem in these patients are the fever may not be as evident as you can see in a otherwise a person, normal person who is not on DMARD NSAIDs. Patient may be taking a regular NSAIDs or patient may be on a small dose of steroids, or for that matter these DMARDs are immunosuppressives, so the fever may not be as high or as obvious as you look at it. It could be a very subtle rise in temperature, or patient may just feel fatigue, weakness or a sort of exhaustion. That could be the only presentation what these patients can present. Even the abscess could be less painful because of the absence of resistance to the abscess growth, and even the symptoms could be very subtle. There could be a huge abscess sitting in the lung, patient may have a very subtle symptom. So, symptoms could be very subtle, and it may be difficult to localize an infection in these set of patients because of the modified immune response to the infection, either because of the DMARDs, NSAIDs or the steroid which these patients are continuously on. Our patient may be developing an opportunistic infection like oral candidiasis. Our patient may have an active tuberculosis. As we have been told previously, the leflunomide can prone or increase the proneness to the tuberculosis. Herpes and other infections could be the planes. Sometime we need to remember, since they are immunocompromised, we need to think about introducing antimicrobials early in the course. So, most of these drugs being immunosuppressives, we need to be careful with even a moderate to low grade of fever what these patients come with. You need to be careful before saying that okay, it's fine, it's a fever, just take paracetamol, etc. But which you can sometimes be little casual about with the patients who are not on DMARDs and immunosuppressives. With the patients who are on DMARD and immunosuppressive, you need to be little more careful with these fevers, that it could be a marker of something which could be more disastrous. So, in addition to that, the antibiotic prescriptions and minor drug interactions you should see, and often the clinical features could be subtle and could be misleading. So, in these patients, before you come into conclusions, there are some simple clinical guidelines on which you can assess whether patient is severely immunocompromised or not, because that is one of the important questions which we need to address when a patient on a DMARD or an immunosuppressive comes. For example, if the patient developing repeated oral candidiasis documented by you or seen by you, or patients developing repeated oral ulcers, or who had a recent herpes zoster, say he says 4 weeks or 6 weeks back I had a zoster from which I have recovered, now he comes with a fever, or the skin fungal infection, extensive fungal infection in a non-diabetic patient who is on a DMARDs, suggests that these patient is probably have a cell-mediated immunity suppression, CMI suppression, more than what we were trying or attempting to do. In a sense, if a patient who is on a DMARDs or a small to moderate dose of steroids presents with oral candidiasis, oral ulcers, zosters, or a extensive fungal infection, it clearly suggests that the drug is interfering more than or extensively on cell-mediated immune response. You need to be careful with these patients. These are the patients who are likely to develop a subclinical or with a minimum clinical symptoms of diseases like tuberculosis, extensive tubercular infections, and even fungal infections which could be extensive. What it clearly tells you is these are the clinical signs of a cell-mediated immunosuppressions. If a patient gets repeated skin biogenic infection, he gets repeated upper respiratory tract infections and oral ulceration, it could be a sign of neutropenia or a impaired neutrophilic functions, because all these drugs what we talk about, the methotrexate, leflunomide or steroids do interfere in the functioning of the neutrophil. Even though if the count is normal, if there is a neutrophilic functional defects because of these drug interference, they may have repeated skin infections, URTA and oral ulcerations. These are the simple clinical guidelines which tells when the patient is on DMARDs to say that the immunosuppression that what I am weighing, the risk that the patient being exposed for an immunosuppression is much more than what is now happening with reference to the relief of the pain. So, see, you need not go with an extensive test to do a cell-mediated immune responses. You need not go to an extensive tests, because these clues in the last 3 months or 4 months tells you likely his immune system is overreacting or oversuppressed than what we are expected. Sometime you may lose up with a combined defect. So, the patient may have both CMI as well as neutrophil things. So, thus when a patient comes with a fever, when it comes with a fever of beyond 2 days or 3 days, it's at best, which may not recommended in a person who are not on disease modifying anti-rheumatic drugs, but the patient who is on disease modifying anti-rheumatic drug, best to check for CBC, blood count. Here you look for leukopenia, low platelets or anemia. If any one of them are present, especially if the leukopenia is present, probably it suggests you that this is a patient who need to be little more careful, because the drugs using most of these disease modifying anti-rheumatic drugs produces neutropenia as one of the problem, which itself could be the increased susceptibility for him to get into fever or any infections. Presence of anemia and low platelets suggests that the bone marrow is in a threat, it could be suppressed. In addition to that, how to interfere this, how to interpret this leukopenia, I think we will be discussing in the afternoon sessions, how a patient suddenly comes with a cell count drop, how exactly we need to approach it. If the patient has been given anti-B cell therapy, say if the patient has been given 2 months or 3 months, even 6 months before a rituximab, Rituxan, any one of these anti-B cell therapies, one need to think if the fever extends beyond 3 to 5 days, is it because of drop in immunoglobulins? There could be a reduction in immunoglobulins. It's best to check out his immunoglobulin level status, because that could be the reason for his increased susceptibility of infections. If he rolls towards a severe infection, these patients are benefited by supplementing with IV immunoglobulins. These are the candidates where a supplement of IV immunoglobulins can literally save these patients. Liver function test, renal function test may be required. It here depends on your judgment. If you think so, there could be a possibility. These are required because patients on methotrexate, leflunomide, etc., these functions could have been disturbed. That may be reason, and that may be one of the base background on which you need to plan your antibiotic therapies and other interference. So in a nutshell, this is a little crowded slide. I think I have given the reference. You can see it. It's available in. It's an open access journal. In any of these high risk patients where the fever extends beyond 4 days, your caution should be there. These patients should be cautiously worked up with. So if you have an unexplained fever, clinically stable, counts are fine, you feel that the bone marrow is working very well with the defense, you don't have much findings that I said clinically, he doesn't have an increased infection in last 3-4 months, his immune system seems to be adequately okay, carefully observe him, ask him to respond or report to you if he finds some symptoms like a sudden fatigue, increasing pulse rate, feels too exhausted, and there is any signs and symptoms of a dropping pressure, etc., to report immediately. Then you need to work up thoroughly for any other focus of infections. If patient is still an unexplained but receiving or requiring fluconazole or yeast prophylaxis early, that's what I said, if there is a chance of increased fungal infections, etc., they need to be preemptively treated with antifungal or any other. If he had any other infections receiving prophylaxis, he needs to be treated and managed in that particular lines. If you are able to identify a focus of infection by the symptoms, proceed further without much wasting time and identify the focus of infections and treat him at the earliest, because as we are very clear and we are aware, if I handle infection much earlier, the likely recovery is better. Even if you delay sometime in 24 hours, a patient with an infection can roll into sepsis. Once he rolls into sepsis, the outcome is disastrous. So that being the case, in a patient who is immunocompromised or on disease modifying anti-rheumatic drug, a fever of greater than 4 days should alert us. And we need to classify and group them accordingly, who requires an higher attention, who do not require an higher attention. Because biggest challenge for all of us is, should I investigate him further or should I stop short here? Because that's a major issue we have. If I ask more, there is a criticism you ask too much. If you don't ask more, in the consumer court he tells you that, why didn't you do this test? I was an immunocompromised patient. Of course, he will not ask, his relatives are going to question you there, that asking him, we would have paid for all these tests, why didn't you do that? See, that's a basic issue. This is just a general guidelines, it's need to be practically applied when it comes to the case by case. So next comes is the drug of choice. So check on the drug interaction before you prescribe any of these antibiotics, and it is preferable to use bactericidal in immunosuppressive patients rather than bacteriostatic drugs, and use discretion to stop anti-arthritic drugs, because sometimes stopping anti-arthritic could be potentially problematic, because immune system which is partially suppressed, if you suddenly release it, it can produce something what is called as immune resurgence syndrome. So that it can suddenly worsen the whole disease process. It's always, you need to keep it under control, and if you have to release it also in a controlled manner. So you need to be clear, and you can always check with the rheumatologist or anybody who is prescribing those. And if the patient is on steroid, think twice, not twice, think 101 times before you withdraw the steroids, because patient may suddenly land up in Addison crisis. So you need to be careful when the patient is, especially on a long-term steroid, suddenly freezing the steroids. I do have seen the patients being moved to ICU because the treating physician has stopped the steroids when the patient, and he has been shifted to ICU only to be given 3 doses of hydrocortisone of 200 milligram. He is back with the normal pressure, shifting back out of the ICU. So it's always better to think twice in a long-term steroids patients to stop the steroids instantly. They never take such risky decisions. So in addition, we need to look into these patients about the adverse reactions. It's best to keep the total information on the drug adverse reactions. So when you have referred a patient, it's not just that the rheumatologist has to remember about the adverse reaction of methotrexate, it's a necessity. The reason why I emphasize, why I take up this much of CMEs, etc., is basically for everyone to understand, because this patient has been given by a methotrexate by the rheumatologist. These are the probable adverse reaction. We need to remember that, because each time you can't call the rheumatologist who is taking the treatment, who is giving the treatment, and we need to know what are the probable adverse reactions. This is going to help us to check on these possibilities, and if it is, one can, of course, in the worst scenario, you have the rheumatologist who can help you out. The next question comes is in the operative and perioperative period, what we should do with reference to disease modifying anti-rheumatic drug. This is a huge debate. The problem when the patient walks into a surgery is that these drugs being immunosuppressive, whether it is going to increase the infection rate. The next is, we all are being tutored, told about is steroids and some of the antimetabolites can interfere in wound healing. And the next problem we have is the drug interaction, which is including anesthetics and the post-operative drugs, antibiotics which we are going to prescribe, is it going to create a problem? And large concern of any surgeons or anybody who is managing these patients is the complication, both pre, peri and post-operative complication, is it going to be increased because the patient on disease modifying anti-rheumatic drug. There is a very nice review, of course it's set to be published, I couldn't see where it was published. It was a report on evidence-based recommendation from British Society of Rheumatology. It was a A1, A02 review, wherein they tried to analyze the available evidences on the peri and post-operative managements. But there was no adequate studies available throughout which could address that issue. That being the case, they are silent about the recommendation. So that's why probably it didn't got published. They just published whatever the reviews they have done. There are very limited amount of publication which has addressed this question. We have a good amount of, very few fairly amount of publication with reference to methotrexate, which clearly says that the continuation of methotrexate is not going to increase perioperative and post-operative complications. There is an exception which is given. Elderly patients, frail patients and patients with renal insufficiency, it is preferable to stop the methotrexate in these set of patients. The reason is the patients with the renal insufficiency and in the frail elderly patients, the methotrexate toxicity as such is high. By adding few more other hepatotoxic drug during perioperative period may increase the toxicity. So that being the case, with an exception of these, the most of the methotrexate has been recommended to continue. There is no adequate available literature to say it, but currently, since we are worried, as I said in the very first thing, our response is to be safe until we have a stamp that it is safe, but currently we feel it may not be safe to continue these drugs during perioperative and post-operative period. It can be stopped for a week or plus and to be followed by resumption of these drugs once the patient's wound heals completely. But we need to remember all these patients of rheumatoid arthritis, even after knee replacement or even knee and hip, all the 4 hip being replaced, we need to remember that there is another 56 joints which should be taken care in these patients of rheumatoid arthritis. Disease rheumatoid do not stop by just replacing 4 of the joints. So that being the case, any patients of rheumatoid arthritis who goes for a replacement, his disease modifying anti-rheumatic drug should be resumed within next 7 to 14 days or the day when he is fit to resume these disease modifying anti-rheumatic drugs. Very frequently we do see, I think most of my rheumatology colleagues do agree with it, that the joints are replaced, DMRs are never resumed. Somehow the patient manages his pain for some more time, he comes back with the relapse of the arthritis. I can tell you, if you don't replace the disease modifying anti-rheumatic drug in the early 2 weeks, his outcome with reference to the replaced knee joint also fails. The reason is the pain in other joints are going to hamper the mobilization of the knee which you have replaced. If the knee is not mobilized in the first 6 to 12 weeks, the patient's range of mobility which he is going to get with the replaced knee joint or replaced hip joint is going to be very low. So end result, what as a surgeon you are looking at is an increased mobility of the joint. What the patient is looking is also the increased mobility for himself. This is going to be failed if the DMRs are not resumed within next 2 to 4 weeks of our best is to introduce within a week once the wounds are healed. So that gives the best outcome with reference to the perioperative states. So what I mean here is, in the end of the day, handling the rheumatology or any autoimmune disease is a coordinated effect. A perfect coordination between the family physician, specialist, generalists and surgeons is a requirement when we are handling these patients. So it's not that he is not a human being once he gets a rheumatoid arthritis. He is an individual who can have all the problems around him. So each needs to be managed, and it should be managed with a coordinated efforts which is going to improve the outcome and a good life to this patient. So in a nutshell, a patient on DMRs or an immunosuppressive needs a special attention. We need a good focus on the issues that we need to address with reference to these patients. It could be subtle to a major consequence. If we handle them, really the outcome of these patients are good. Thank you very much for patience.
Thank you, Chandrasekhar. We'll take the question after Arvind's